We are live.
This is the Senate Appropriations Committee. It's March 10th, and we're doing FY27 budget presentations. We have the entire Agency of Human Services here, or a good portion of the key people. So I'll let you introduce yourself and give us your presentation.
Great. Thank you, Chair. Good afternoon. I'm Jenny Samuelson. I'm the Secretary for the Agency of Human Services, and I appreciate the opportunity to bring our executive leadership team to the Senate Appropriations Committee today. I'm here with our Chief Financial Officer, Tracy O'Connell. I'll let her introduce herself.
Yes. Good afternoon. Tracy O'Connell, Chief Financial Officer with the Agency of Human Services.
So we'll go ahead and we'll get started. As everyone here knows, the Agency of Human Services includes 6 departments, including the Department for Vermont Health Access, the Department for Health, Department for Mental Health, Department for Children and Families, Department for Disabilities, Aging and Independent Living, and the Department of Corrections. It also includes the Secretary's Office, which houses the Office of Healthcare Reform, the Blueprint for Health, and the Vermont Chronic and the Refugee Resettlement Program, and other programs. Overall, the Agency of Human Services budget as proposed is $3.75 billion across the agency. In the first slide, which we're pulling up now, just give us a second, you can see the distribution of those funds across the departments.
I'm sure you have this somewhere, but what's the percentage increase from last year? Did you say within the 3% goal? Or?
Yeah, so our percentage increase over the last year, which was 2 slides up, is 6.1%. For the general fund budget. Okay. So as a reminder, the Agency of the Human Services is one of the largest agencies in state government. In addition to our budget being $3.75 billion, we have a total of 4,136 positions across all departments. For our budget this year, what you're seeing is an increase of $86.1 million. That's a 6.1% increase, as I said previously. The way that that's split out is just under $75 million, or 5.3% of that is an increase in order to keep our current programs that we have running and on the ground, so base funding for current programs. In addition to that, there's an $11.2 million increase, or a 0.8% increase in directed towards the base for base initiatives.
Is that a 0.8% of general fund, or the just base?
0.8% of general fund.
From last year's base, I guess. So
into next year's 2027 base. So one of the things that's going to be key to our discussions today is how we came to our budget this year, which differed significantly to the process that we've done in the past. The team that you have here today is the executive leadership team from the Agency of Human Services. They're the ones who are responsible for developing our budget. The executive leadership team includes myself, the secretary, our deputy secretary, our Medicaid director, and our 6 commissioners across the department. We view it's an important role for this group to play in both identifying the priorities and programs and allocating the resources, both human and financial resources, across the department in the budget development and policy process. So the way that group went to the budget this year is we started early in the year identifying what our priorities were. First, we started with the governor's priorities, which won't surprise any of you. They included growing the economy, making Vermont more affordable, and protecting the most vulnerable. The Agency of Human Services also went and identified, based on the governor's priorities, what the priorities for this coming year would be for the agency. They included housing, with a particular focus on addressing homelessness, looking at substance use and mental health integration across the full continuum, and particularly looking at co-occurring care, treatment, and prevention. So all the way across the continuum, making sure that we were both stabilizing that system and creating a co-occurring system. We looked at healthcare affordability with sustainability and quality in mind, and looked at making sure that we had a strong and resilient workforce within the agency. One of the things that was key, that was different, once we identified what those priorities were, we worked to evaluate the programs across departments and present that data to the commissioners and the executive leadership team, and to identify that with we have our Medicaid director and policy director convene the Medicaid program, so that we're looking at the Medicaid program across the departments because it sits in almost every department. In that, we work to evaluate which programs were the most effective and which were no longer effective in that initial take.
You have two different effective, maybe you're going to talk about this later, effective measurements for different programs, or was it just some like general effectiveness?
Yeah,
measurement?
so we looked at effectiveness and were they achieving their outcomes that they were intended to achieve. We also looked at were they equitably distributed across the state. The agency on multiple occasions has started a pilot program and not brought it all the way to scale. And so we have pockets of where Vermonters could get services, but they weren't equitably distributed across the state. We also looked at where there was a creation of duplication over time. So for example, one of the programs that you'll see noted this year that we looked at carefully was the fact that over the last few years, we've worked to stabilize the mental health crisis system of care. Since the pandemic, we put in place 988, mobile crisis, and alternatives to emergency departments or mental health urgent cares. They've really strengthened that system of care. And so where there were individual programs on the ground, but were not scaled across the state, there was some duplication in some of those efforts. And so we looked carefully at where we could evaluate duplication. When we started the budget process, so once we identified the priorities and looked at evaluations of programs, we took an inventory of our current services and looked across the state. In order to keep our current programs going, it was going to be an increase of $117 million. As that compared to the 3% budget target, which we anticipated before, because that's what it's been for the last few years. During the summer, we estimated that our total target would be a reduction of $42.4 million. Or the increase was $42 million, excuse me. And it meant we were looking for a reduction of almost $75 million just to keep the lights on in our current programs. At that point, departments and the agency came forward with opportunities for savings and reductions. We really looked at that in several different ways. Where were there revenue offsets? Some of the things to keep current services going we knew were actually revenue declines, but there were places that we saw increases in revenue. We looked for administrative and program efficiencies, and we'll go through each of these and what we identified in the final budget. And then we went and looked at places where we could do programs and services reductions based on that evaluation that I just talked about, prioritizing where we could make reductions. There were some I want to acknowledge there were some hard choices that we needed to make, but we feel like we really balanced what the needs were of Vermonters as well as our fiscal responsibility.
Yes,
thank you. So on your slide, you in that last point, talked about the potential savings for non-essential, non-mandatory, non-statewide. I'm wondering about the non-statewide aspect, just because of what you said earlier. You looked at how services were distributed across the state. I'm wondering if a program was not equally distributed across the state, was that just eliminated? So
we took and evaluated whether the program was what were the reasons that it wasn't statewide. Mm-hmm. So for example, some of the programs that we don't have statewide, it's because we don't need everything in every community. Some things need to be at the state level, the regional level, and we don't need it across the state. In other cases, there were programs that for certain reasons we chose not to scale, but which we felt like we needed to have, that weren't necessarily as effective. Mm-hmm. And so for equity reasons, we may have chosen to eliminate them. There were other places that you'll see, for example, in rural health transformation, where we had mental health urgent care, mm-hmm. where we knew we needed to get to scale. Mm-hmm. So these were programs that were orphan programs, mm-hmm. that were out there that had not gotten to scale for specific reasons, and we didn't think would ever get to scale, and were inequitably distributed
Okay.
and not achieving their outcomes.
So it sounds like there was just like a whole variety of situations.
factors.
Yeah, with those non-statewide. Because I was worried that, I mean, it sounds like this was the case for some of them, but that if there were services that were being offered, but they weren't statewide, that, you know, because that's inequitable, closing it down for everyone.
We looked at the why.
Yeah.
Why wasn't it statewide before we made those decisions? And we spent the majority of the summer working through this, several hours a week, to really carefully evaluate it. And this year, I think what's different is it was the entire executive leadership team of the agency. At the times that I've been at the agency, we've taken and we've had one department propose a solution that they knew was going to have an inordinate impact on another department. Our executive leadership team took seriously that they have two major responsibilities. One is to be an executive leadership team member for the agency, making decisions that are right across all programs. And the other is to be for their center of excellence, for them to run their departments. And they take both of those roles incredibly seriously, and made sure that as they were making decisions this year, it was based on what was in the best interest of Vermonters across the entirety of the agency. And that was a fundamental difference in the way that the budget worked. In the past, they have each developed their own siloed budgets based on a projection, and then based on that, it's kind of been like a Shark Tank, where they come to the secretary and propose those, and at times we've had to figure out where it was going to have an impact, and it's just not the best way to do.
So each department did this evaluation, then brought it to the whole team, and decided as a whole team what cuts in it.
So the evaluation of the Medicaid program was done across the Medicaid program with almost all of the commissioners minus COC, who has less Medicaid. And then the evaluation and the presentation of that evaluation data was brought up to the executive leadership team and proposed and demonstrated and shown to them. Does that make sense?
Yeah,
Okay.
sounds good.
Okay.
Okay, so now we'll get into the numbers. Here, this slide shows the different categories of the current services that we were witnessing for pressures. The two biggest areas, revenue loss and caseload and utilization.
What do you mean by revenue loss?
Loss of federal funding mainly, or special funds.
We're going to go right through that.
Yeah, we're going to get right into that. So $26.6 million general fund is needed to backfill a loss of revenue for number one, global commitment, the base FMAP change. In 2026, the federal matching percentage was 58.81%. And in 27, it will be 58.07%. So a loss of 0.74%, which equates to $13 million general fund we need to backfill that loss.
We want to acknowledge that this one is a usual and normal change that happens in the Medicaid program every year. We've gotten the question often, is this something that has to do with a change in the federal administration? And the answer is no. This goes up and down every year. It's just the last couple of years it's gone up, and our FMAP rate is higher than it's just about ever been.
The next two are more,
The next two, yeah.
Well, the second one
The
is
rate, the FNF rate, meaning that our share.
yes. So the federal FMAP stands for Federal Medical Assistance Percentage. So that's the federal share. So the state share will go up or down depending on
it's formula,
What's that?
it's formula driven.
Yes, that is
Yes.
correct.
And that formula hasn't changed. So last year it was 58.8%, and this year it's 58.07%. And the way that they calculate that has been consistent year over year for many years.
Is that part of our waiver?
Yes, it's part of the Medicaid program.
Yeah, each state has a different FMAP rate, and it is based on a formula across the entire country. Some states the minimum is 50%, which a lot of states just get the minimum. But we get 58.07.
No, and
It's based on a 3-year average of per capita income relative to other states. That's the high level explanation of the
And
formula.
it doesn't have to do with I thought there was a connection to our waiver, like we give
No.
more flexibility, but we
No.
have to pay more.
Now,
No.
if you want to come in and do a
Proportions,
30-minute presentation all about FMAP sometime.
Better line.
It's not specific to our waiver.
Okay.
It is the way that they set the matching rate for all Medicaid programs regardless of waiver.
We did get bonuses during COVID.
That is correct, across the country, yes.
Where does that put us in the grand scheme of things with other states?
I don't have that information, but we can follow up.
But compared to where we've been over the last several years as Vermont, it's considerably.
So the second area is $4.5 million general fund to backfill loss of SNAP federal match. That's related to administrative costs only. Previously, the federal government would pitch in 50% match, and now they will only do 25%. So this represents the backfill for that 25% loss.
And this is a recent federal change as from last summer.
And then the third item is for the Child Care Special Fund revenue downgrade. So at the last e-board meeting, there was a downgrade for the collection of the payroll tax. And so we need to backfill $8.7 million in general fund for that. Now moving on to caseload and utilization.
Before we go on there, am I remembering right that uptake for the child care program is now where it needs to be?
Correct. We did not adjust utilization for the budget because it's showing right where it needs to be.
Okay,
What
great.
do you mean needs to be?
Well,
Where it needs to be as far as what, making revenue and expenses to be equal?
So based on the whole program, if that's what you're asking, like, because there's general fund, there's special
Well,
fund, there's federal funds.
and there was a ramp up in terms of.
Correct.
And so for a while, we were doing things with that unused revenue. Now we're putting it all into the child care.
Correct.
Yeah.
For caseload and utilization, $27.8 million general fund. The bulk of this is related to Medicaid consensus. This is a similar number that we saw in budget adjustment. 14.9 million general fund or 33.3 million global commitment. We are requesting $1.5 million for the clawback payment to the federal government. And for developmental services in Dale, $4.1 million general fund or 9.9 million global commitment. And also in Dale, choices for care related to nursing home bed days and HCBS spending, $4.4 million general fund or 10.6 million global commitment.
And then are those also similar to other years? These kind of adjustments?
In terms of increases,
Yeah.
we can look at getting the departments to bring in year over year, but they're not outside the norm.
Right.
Moving on to salary and fringe for the entire agency, $21.3 million general fund. This does include almost $500,000 for 12 new HAYU staff at DEVA that will work on the Medicaid work requirements and biannual redeterminations as a result of HR 1. And then for operating expenses, we need $6.5 million general fund, the bulk of which is for the internal service funds, which is HR, the insurances, ADS, and then $192,000 for the DEVA Pilgrim Park lease, and then about $1 million for DOC vehicles, uniforms, and other.
Sorry, I just need the acronym there.
Hey, you?
Hey, you.
Oh, I'm sorry.
The Medicaid Enrollment and Eligibility Unit.
Okay. I can accept that.
So what this one is that in HR, we move from redetermining individuals for Medicaid from every 12 months to every 6 months for those who are in the new adults, so those adults who were childless adults. And so HAYU is the unit that actually actively does eligibility and enrollment.
Okay. Thank you.
Yep.
Contracts, $17 million general fund. Many of these are the same pressures that we saw in budget adjustment. I think the only new one is related, the last item, the DOC transitional housing, 247,000. This represents DOC already funds this program, but the program lost federal funding. And so we're seeking to help backfill that with this request. The next request is for $10.6 million to annualize multi-year programs that have already started. So for example, with the Medicare savings plan, we need $2.8 million general fund or $11.2 million global commitment to annualize that program.
I'm on the previous slide, looking at the DMH forensic evaluations there. And so what all is included in that, and what, if anything, will be affected with the current forensic facility bill?
Yes.
Is that something that maybe?
Commissioner Hart usually wants to comment on this for the record.
Sure. For the record, Emily Hawes, Commissioner for the Department of Mental Health. Related to the DMH forensic evaluations, those are specific evaluations for competency that are ordered from the court. And so DMH is a sort of a pass-through. The court manages how much of the ordering that they do or don't do, and that would not have a direct impact on the forensic facility proposal in S-193.
Can you walk through why we're seeing the increases?
Sure. So a couple of reasons why we've seen an increase with our forensic evaluations. One, that the state of Vermont orders more forensic evaluations. We order more forensic evaluations for Canada nationally. So quite a few come through our court system. We've also seen a shift in who is ordered for a competency evaluation. Traditionally, it was individuals with a severe and persistent mental illness. It is now individuals with chronic substance use, perhaps traumatic brain injury, dementia, all sorts of complex issues that can impact somebody's competency outside of mental illness.
In addition to that, you're seeing a significant number for minor crimes, so for.
Correct.
And a significant number of repeat evaluations.
That's true. From a charge perspective, Vermont orders several competency evaluations as they relate to individuals who have been accused of a misdemeanor crime. And oftentimes someone may engage in that behavior multiple times over the year. If those cases aren't combined, a court system often orders multiple competency evaluations for multiple misdemeanors. And in some other states, there is not the ability to order a competency evaluation for misdemeanors. Those individuals need to go through a more court diversion process versus the competency route. And that's usually because competency or not competency doesn't necessarily quicken someone's engagement with treatment. It can often delay someone's interaction with the treatment system.
Yes, I agree.
Just a quick question about the overall presentation. So I understood you to be saying you had to cut a huge amount.
We're getting
of
there.
your budget. Okay, so these are things that you can't cut that are driving the increase, but then you'll later detail the cuts.
That is correct.
Okay, great.
You had to make the cuts to meet these needs.
We had to make the cuts to go back to the beginning. We had to make the cuts just to make current services, many of which are which include these pressures. So caseload and utilization pressure, as you remember, was one of the highest, and the second one was lost revenue. And so in these areas, you're beginning to see some of the current services pressures based on those things.
Back to the annualization of multi-year programs. So the Medicare savings plan that went live in January. And so we have 5 months built into the base. And so this annualizes it in state fiscal year 27. The DMH alternatives to EDs, this was previously funded by the HCBS spending plan that is about to expire, and so this annualizes the backfill of some of those successful programs. And then $7.5 million for shelter investments. 1.3 million is related to the cold shelter investment, and then 6.2 for the hop shelters. These that were started with one-time funds, and so this builds it into the base.
Yeah. So these aren't new, these are just one-time funds in the base.
Yep. 6 million for provider rates. This list of rate increases is related to either federally required rates increases or state rule required rate increases. So for NFI, Northeastern Family Institute, that rate is tied to the it's a reference-based pricing towards inpatient rates. And so we need to come up to speed on that for $600,000 gross. And then for the FQHC and the rural health clinics, 2.73%, that's federally required. The PNMI rate increase, that is state required. CCBHC, that is also federally required. Once those providers come online as a CCBHC, we have to pay their actual costs. We have to rebase and set rates according to that. And then the nursing home inflation, that's a state rule. And so that's 2.3 million general fund or 5.4 global commitment. So now we'll get into the areas of savings. This chart depicts the various categories, and we'll do a flyby on all of these. So we were able to identify revenue that could help offset some of the pressures. One is in the area of global commitment, the childless new adult group. That's matched at a different FMAP, that's 90%. And so based on the utilization of that Medicaid eligibility group, we can reduce our general fund request by $3 million. With the CCBHCs that I just described, because we have new sites coming online, that is actually matched at an enhanced FMAP as well. That is at 70.65%. And so that is less general fund that we need to implement that program.
Sorry, CCBHC.
Sure, I'll answer that way. Emily Haas. So CCBHCs stand for a Certified Community-Based Integrated Health Center. And that is a federal model designed to increase access to both mental health and substance use services at the community level. Very similar to an FQHC model.
Thank you.
Yeah, the great thing about that is it provides a set of standards that do integrated care so that they're getting both physical, mental health, and substance use treatment all in one place. And it sets That's great.
FEDH, substance use treatment revenue adjustment, the department was able to maximize more dollars on the block grant, therefore reducing its reliance on general fund and global commitment. And then at DMH, we anticipate to be able to increase Medicaid billings for those lengths of stay under 60 days. We can actually get global commitment for those dollars and for those stays. And then with DIVA, we are proposing to increase the prescription drug copays. Currently, they are set at $1 for preferred and $3 for non-preferred, and we are proposing to go $4 preferred and $8 for non-preferred.
And these were initially put in place in 2001 and have not been modified since that point. In addition to that, HR mandates, doesn't mandate increases, but it does mandate shared requirements with Medicaid program recipients.
That's a big increase. Going up to 4 and 8 from 1.
We have a few areas of caseload and utilization savings. First at Rutland Regional Medical Center, level 1, those not all the beds are being utilized, and so we are reducing by $718,000 general fund, or 1.7 million global commitment. And then in DCF, a few areas of caseload reductions, reach up and substitute care, and then Dale with the adult day health and rehab services. We did find some administrative efficiencies within the agency, so all departments reduced their travel, equipment, supplies, fleet, contract budgets. That's $811,000 general fund. DMH and DOC updated their vacancy savings numbers based on the vacancy savings chart that the secretary presented earlier. And then Dale made a technical correction for their other personal services.
Are those vacancy savings positions that you can't fill, or you're choosing to fill to meet the budget cuts?
So while over the last several years, we'll take the VPCH, the Vermont Psychiatric Hospital. What we have seen is that their vacancy rates have gone from 65% to 30%, so they've gone in the right direction, but they are now hovering at a relatively consistent place and space. The same thing with DOC, the vacancies have gone down significantly, but they are now hovering at around the same place. I hope that we will be able to hire. We're not reducing positions in most cases.
And you're not holding,
And we're not
especially
holding
for the
up,
corrections, I hope you're not holding those.
we're not
positions
holding
up.
up hiring or recruitment, but this reflects, this is a reflection of the reality of what we are currently seeing on the ground.
The agency also identified some programmatic efficiencies, $6 million. So the first item, $450,000 general fund savings. There's a proposal to move the school-based services program from AOE and VDH over to DIVA. So this reflects the VDH portion that is no longer needed because there's a contract related to a random moment time study that helps administer the program, and so that will no longer be needed, and DIVA will be able to pick up that work. DIVA is proposing to implement utilization management for durable medical equipment, which will see about $922,000 general fund savings, or $2.2 million global commitment. The next item related to the applied behavioral analysis. This was already in budget adjustment, and so this is annualizing this reduction. In DMH, we are proposing to reduce the amount of beds at VPCH from 25 to 21. That's $1.4 million, and that's related to a unit that is already offline
It reflects current utilization of and census of the program and what it has been since post the pandemic.
I would just,
Yes.
if I might insert a caution around Woodside. If you remember, when we closed Woodside, we did it because current utilization had gone down so low. And so we saved $3 million, and we still don't have a replacement for that facility, and we have need for it. So just a caution, and I'm not telling you anything you don't already think.
No, I appreciate that. The good thing about this that's slightly different is we're not closing the whole facility, we're just closing one wing. So there is the opportunity if we saw utilization shift.
Yeah.
But I do think Senator Burt, that is a good cautionary statement. This does reflect the utilization that we've seen over 4 years. And so we've been waiting, monitoring and watching. But this also, because of staffing, we haven't been able to open that unit fully, and it doesn't make sense to continue to maintain some of the ancillary positions to have a 25 bed facility when really we're just going to sit at 21 unless we see utilization. So, but it is a very good caution. We're not flattening this one.
And then the last item is for the ARIS payroll benefit percentage withholding, $1.9 million general fund. ARIS is the fiscal processor of the payroll for the independent care workers. And there's excess cash on hand there.
Yeah, so in this case, there's no reduction to actual money going out the door. It's just money that's been sitting and held there for a period of time. So it won't change anyone's pay.
So here is where we highlight some of the program and service reductions or eliminations of $9.9 million general fund. And I will just also say that I think Amy's, the summary spreadsheet everybody should have that kind of lays out all of these in detail.
I have them right here. This is
Yes.
good time to hand them out.
Sure. So this is
We printed them on
This
big.
is like a repackage of the AHS ups and downs. It's every line item but more condensed for easier reference. So the full list of the reductions and eliminations.
The orange highlights are reductions, the blue is the other change. Okay.
The blue are the reductions, actually.
Other way around, yeah.
So we'll go over the high level reductions, but if anyone has any questions on the details.
And it's something you can look at over time, you don't have to do it now.
Yeah, this is just our presentation references just a snippet, but there are quite a few, for what the secretary said, there are a lot of little ones, that maybe, I think one was $5,000, so we're just being transparent in everything that we propose for elimination, but it's on that bigger sheet. So the first item is the refugee transitional housing program. There was $900,000 built into the base a couple of years ago, and due to less refugees arriving, we felt it was acceptable to reduce this by $500,000. Still leaves $400,000 in the program for actually, we're going to not use it so much for transitional housing, but more for support services, wraparound services, language assistance, whatnot. The DEVA legal aid Medicare assistance contract. This is a proposed reduction that is not seeing results that it is intended for. It's actually in statute that this contract, the cost of the contract, they should recoup monies from Medicare at the same level that the contract is for, and that you're just not seeing that to be the case. So we are requesting to repeal that.
Sorry, I want to go back to the refugee transitional housing point. So is that money that, say, a refugee family who is here would use, and because it's transitional, then they get into long-term housing, then they don't need it. So it's not, this is not money that
It's not for
a
long-term
family-
housing.
it's not, okay.
It's just for when they first arrive here in Vermont,
Okay.
to get them on their feet, on the ground. It's not the long-term housing dollars. Because we are seeing a significant reduction in the number of people coming in, we're just unfortunately not seeing this program being utilized. And so this is a way for us to take what is reality on the ground.
Yep.
And resize the budget. What we didn't do though, is we didn't eliminate it. We just made sure that we cut it so that it was there and available if things were to change.
Okay, thank you.
In the Medicaid legal aid contract, is that the whole contract?
Yes.
The ACO per member per month payment, with the ACO sunsetting last year, this was an add-on payment, $2.1 million general fund, so $5 million global commitment that we're eliminating from the budget. The next two areas are at BDH, the AHAC reduction and also the education loan repayment. We're hopeful that some of the education loan repayment money, we think it can be repurposed within RHTP. And so
So does it eliminate the program, or are you just reducing the cost?
this proposal is elimination.
Yeah. And so the rural health.
Is everything on this list elimination? Because it says reduction / elimination.
Everything,
It's, some of them are reductions, and so we can go
Yeah.
through, like 211, for example, if you go down, it was a
Right, that's
reduction of the total, of the hours, because that's right now, DCF funds 211 to provide housing placement after 11 o'clock at night. There's no more ability to place folks into the GA program, and so they simply call and they get told to call back in the morning, not a good use of resources.
If they're calling for housing.
If they're called there, yes, and
If
they
they're
are
called for
calling
something.
for help. That is the primary reason that they are calling at night, is for calling for housing.
If you're calling at night, yeah.
DMH outpatient services for TBI, elder care and reach up, $1 million general fund and $1.9 million global commitment.
So those three are connected because they're all outpatient, because I was thinking, what's the
Yeah.
connection to TBI and reach out? That's because they're outpatient services for people in those.
Correct. And we believe that there's other areas that they can access services within the AHS budget. Reduction of 248,000 for care coordination at one family practice.
One of those programs that hadn't gotten to scale, there's only one family practice who receives this. And so we're adjusting that.
We talked about 211, the DCF strengthening families, 498,000, or $1 million global commitment with Act 76 funding. We believe that the funding is meeting the needs of the families via other avenues with that funding.
Can we go back to the education chain, the education loan repayment? What professions? Because that's Department of Health. What professions were those?
Raquel Grant, Commissioner for Department of Health. So the VSAC funds are primarily in nursing. There are some funds, a small amount that are also for hygienists, physicians, and ancillary workforce, but most of it goes to nursing.
Okay. And you're eliminating entirely. This is one of the ones that's an elimination, not a reduction.
That's elimination.
Elimination, correct.
It's not the only funds that VSAC receives, but we're proposing eliminating it from.
What was the reason for that? Sorry.
Yeah, no, we had to make some really challenging decisions. I just want to acknowledge that this year. We started the budget process, as you'll remember, with $75 million that we needed to find in the budget. In some cases, we were balancing cutting things that were direct health services to Vermonters with education, with things like educational loan payments. When we saw the opportunity for the rural health transformation funding, we realized that we could invest significantly in workforce initiatives that were similar. I'm not going to say that they're the same, but that are very similar. For example, the rural health transformation funds allows us to pay for tuition for individuals while they're in school as an option with a guarantee for them to continue to stay in Vermont. We felt like we were able to achieve some very similar outcomes while also trying to make very difficult decisions.
Okay. Sarah Lyons?
As long as it's not in Chittenden County. I mean,
I want to be
rural
clear, we're
rural health
working on
transformation.
the definition of rurality. We don't know what the definition of rurality is here in Vermont. We are working within the bounds of the federal program. And so, again, it's probably, we can spend more time if folks want, but for individuals who are not living in rural communities and for providers who are providing only services in more urban communities, there is some challenge with finding, with funding for under rural health transformation. Again, rural health transformation is intended to put dollars to serve rural communities and rural providers. So I do want to acknowledge we're working on that definition, and we don't have full clarity from the federal government about what these restrictions are.
Okay, Senator Bruce, and then Senator.
So building off Senator Lyons' question, is the money that you're foreseeing filling some of this need already available, or is it anticipated?
Oh, we received $195 million from the feds.
Yep.
That we need to, like that first $195 million needs to be spent before the end of the next federal fiscal year. It's available to us now.
Yeah.
In most of the areas that we applied for, and then it needs to be spent by October of next year. So yes, it is available in state now. Those programs are being launched as we speak.
Okay, and then beyond what you have now, this is a revenue stream that will continue?
The revenue stream that we will have, we hope that we will have for 5 years, as long as we're able to get the funds out the door and show the outcomes. The state of Vermont has been approved for $195 million. Every year, they will rebalance that amount based on our ability to achieve our outcomes and get the money out the door.
Okay, I would just echo Senator Lyons' concern about Chittenden. If we lose out on that funding, although Chittenden County has many rural areas, if we lose out on that and this program goes away, it's just a net loss for our nurses, our nursing students.
Yeah, we have this funding for the next 5 years, and for folks who will go into rural communities.
But if Chittenden is, as I understand it, Chittenden is currently excluded.
Yeah, Jill, you wanted to say pieces, but I want to be really clear. We don't have the definition of rural yet. So I've heard a lot of providers in the building spending a lot of time saying that they know that they will not get payment until we actually have completed and gotten an approval for Vermont's definition of rural. That is inaccurate. We're happy to come back to folks when we have that definition. Yes, there will be some challenges with paying for providers who primarily serve Vermont urban families. But again, that doesn't, the new opportunity doesn't necessarily exclude all of Chittenden County. We are working on that definition. Again, I think providers absolutely want to make sure that they have access to as much funding as possible.
Yeah.
But we need time to actually get Vermont's definition of rural. And we need time to be able to get that approved by the federal government.
Right, take your point.
But healthcare but students who are going to school in a Chittenden County, like the University of Vermont, if they are going to work in rural communities, that doesn't exclude them from this funding.
Okay. Yeah.
So Senator Westman, and then we'll go to this.
So here's what is hard. That 195 or whatever, 96 or whatever it is it's elusive for us to know where it can go and what it is. So when you ask us to cut a program, when we don't know whether the money will be available for this or not, it becomes hard for us to judge what to do around that. That's the first part. Where somebody gets taught in a nursing program, the fear really is in all of that, is we know that traveling nurses are eating us alive in Dale, and across the board. And we've done all sorts of emergency aid things that mostly are being cut in this budget to do that. So how is anybody at this table supposed to make a decision about a cut like this when we aren't guaranteed that the money is going to replace it? You just say to us, it's probably going to happen.
I hear your frustration. I want to be 100% clear. Rural Health Transformation funding cannot be used for loan repayment. We all in this room need to collaborate on very difficult decisions about where we prioritize and spend our funding.
Nor can it be used for supplanting something we're already doing.
It cannot be used for supplanting what we're already, but regardless, the Rural Health Transformation Funds, I want to be 100% clear, cannot be used for loan repayment. We will not replace the loan repayment program. So I understand, Senator Westman, your frustration. I am not asking you to buy into the fact that we will have a loan repayment program. We will not. We had to make some very difficult decisions to make sure that we were able to maintain services for Vermonters with the funding that we have in the state of Vermont. And this is a program that the Agency of Human Services is putting forward to be cut. And I just want to be 100% clear that that's what this is. And we present our budget to you, and then you will have to make also very difficult decisions about how you balance the budget.
If there are programs that are not the same, but get at the nursing problem that we're facing, how are we going to know what those alternatives are so we can make an informed decision about whether to keep this?
Happy to come back in and Jill can answer, but happy to come back in and tell you what's in the Rural Health Transformation budget. One of the things that's in there is tuition assistance. And that's one of the things that has been approved. You asked a very specific question. Can we use it in Chittenden County? That we can't answer yet. But is that one of the approved programs that we're putting out the door? Absolutely. And again, Jill would be happy to come in and walk through the full set of what Rural Health Transformation will fund. So Jill?
Do you want to say anything right now?
I do want to say one thing just to add on to what the Secretary was saying in terms of this rural question, which I know is a concern. So we did get some sort of vague new guidance from CMS, which was that states have some flexibility about creating definitions, and yet we still expect that when we actually give them our specific projects to approve, which they will have to do before they'll let us spend the money, that they're gonna expect to see a credible definition. So that's what we're wrestling with. There isn't a definition we can use. we are planning to argue that for the workforce projects in particular, that workforce is something that affects the whole state, that increasing the workforce anywhere in Vermont is good for all of Vermont. That's what I'm planning to say. Whether they will agree with me is a different question. But I feel like if you have a 5-year service commitment and you spend it in Vermont as a provider, that should be reasonable, because you might go to different communities. If you're serving Chittenden County, now we don't need to pull someone else from Franklin County or Addison County to go to Chittenden County. So that's the plan. What we don't know is whether CMS will agree to it. So that's where we still have some uncertainty.
Thank you.
Yeah.
Continue,
I know,
Lions?
I do want to continue. At some point, I'd like to go back to durable medical equipment, which is on the previous page, but we don't have to do that right now.
Yeah, and in any case, I believe that DEVA is coming in to present their budget, and so
Okay.
you'll have an opportunity
We
to
can wait
go
for that.
much deeper.
I would say the health department, I'm scheduled to sit down with the health department. And just as a warning, but I'm going to ask, when you get to things like the education loan, give me an idea of on the ground what's in the grant, side by side, so I can relate. And when people at this table ask about it, I can say, this is what is taking its place in that. Because we don't have time to go through every inch of this but you need to make it very clear about that. It's unacceptable, the number of traveling nurses we still have.
Yeah, we all agree, and that's why we put significant funding in the workforce category of the Rural Health Transformation Funds to help bring us further.
Totally get that, but you know, we know that underlying in this budget, we could get rid of travelers. It's only in our best interest.
I hear you. I think we all have that same goal in mind.
Okay.
Okay.
And then the last item on that list is, DCF reach up agreements and reach first, 623,000.
Can you just talk about where that money is coming from?
Yeah,
Is it a direct appropriation to the families, or is it something else?
there's a number of line items. DCF can speak more to it, but one example is with Lund, reducing the number of beds in that contract because, again, underutilized for a number of years. The Social Security agreement with Daber, and then housing case management, because we have housing case management in other areas within the agency.
So things like the Lund beds, they're in agreement. These are beds that they haven't used for years. Okay. So we also, in addition to looking really hard, remember at the beginning we said we aligned our budget to our priorities. We looked at what were some of our key priority areas. So those included housing, mental health, and substance use as key areas, you'll remember. And so here we looked at DCF sustained investments in emergency housing. So increasing investments in moving them from one-time to base for family-specific housing for those experiencing domestic violence, individuals who are medically vulnerable, increasing those shelter options in each one of those areas. Substance use recovery shelter, we're excited to see one of those open in Burlington yesterday. Case management enhancements and rental assistance. There's also, in addition to those base investments that we're looking at to sustain those programs, we're looking at $21.1 million to sustain the general assistance housing program. That's right now, we currently invest one-time funds. This continues to maintain one-time funds for that. Also also looking at the staffing.
The general fund, the general housing thing, that is, general assistance. Is that 21 more or 21 total?
21 total.
So if I could just ask, I was keeping track of trying to count up to the 70-something plus million that you need. It seemed to me that you broke off with more savings.
Yeah, that wasn't all of us. That wasn't all.
Yeah,
That was
so-
just a highlight.
so what-
These are initiatives though, right?
these are initiatives. And so what I would say is, remember, our original target was set based on us achieving a 3% target.
Yes,
We increased our budget over 6%.
I see.
And so what you will see is that there was 0.8% of that 6% that was attributed to high priority areas. We weren't looking, I want to be really clear, these are not new things. These are things that we would look to continue to sustain. So another example of that is the opioid recovery employment program, which was covered by opioid settlement dollars in the past. We are proposing to put that into the base. It was one of the things that we did not anticipate would get funded from the opioid settlement committee. And based on that, this is a program that actually has shown outcomes. So these initiatives aren't necessarily, as you saw, new things. It's maintaining our general assistance housing program, maintaining our opioid recovery employment program.
Yeah, I'm just finding it a little hard because we've bounced a couple times from cuts to additions to now additions. So I had it, do you have a figure for how much you were able to cut? It seems like 50 million or so?
Just the blue sheet.
41.
Yes, 41 million.
Oh, what is that last number, that 74 million, that AHS current services position?
So that is what our overall budget request is. This is an up of almost 75 million, or 6% that the secretary has, yeah.
And the last program on the initiatives was we have pretrial supervision in a few counties. I want to emphasize that pretrial supervision has been also supported our accountability court this year. And so really what it is working, the pretrial supervision is both doing pretrial and supporting our future initiatives that have been rolling out across the state. It's been this would bring it from the 5 current to 12 to scale across, to make sure that it was scaled across the state. Again, not new programs, you're not going to see new programs here. This is just addressing what we've talked before, where we don't want to have pilot programs that we aren't assessing and then bringing to scale if it's successful.
And on this handout, what's the difference between these changes, this sheet, do you recognize that sheet? And the other
I will walk through what this is so everyone knows at it.
Yeah, so the gold sheet it totals $115.8 million, which are all the current services pressures that we saw in the budget.
And then this thing?
And then the rose colored sheet is for the initiatives.
Okay.
The last slide that we just did.
Okay.
Another lot of changes. So pressures, cuts, additions. That's the way it rolls out.
Okay. Okay.
Yeah, so. Okay, so the AHS central office includes as I mentioned before, includes the secretary's office, the Office of Healthcare Reform, field services, refugee resettlement program, also Vermont. The overall budget for the secretary's office is $30.1 million, with 12.1 million general funds, 15 million federal funds, 2.4 global commitment, and $338 million of interdepartmental transfers. It includes a total of 78 positions. I think it's important for us to highlight in the Secretary's office some of the accomplishments that we have achieved over the last couple of years. Field Services was responsible for setting up the family shelters in Williston and in Waterbury initially. In addition, they've supported the Burlington Accountability Court, pulling together the providers in those areas to provide the wraparound services for individuals. In healthcare reform, they have done they've been working with hospitals and hospital transformation plans, which we think will fundamentally shift what hospitals offer and how they will evolve and change. The Rural Health Transformation Program, that team in record time applied for the $200 million of programs and funding by going back and looking at what in Vermont over the last few years had outlined we wanted to advance healthcare reform. And then in refugees, they've really helped with this year when the federal government cut funding to the refugees in the SNAP program. The refugee resettlement program ensured that there was a backfill at the start to help folks who were coming off of the program ramp down so that there was a softer landing.
So I can't let it go, and that is under healthcare reform. It would seem to me you'd want to have the strategic plan, the action plan that you're also working on, which is significant for linking acute and chronic care, community-based services. So are you putting the Rural Health Transformation Program in there as a replacement for that?
I want to be clear, these are accomplishments, things that we have done. We are still working on the strategic plan, and it's a high priority for the agency. But, you know, I think we spend a lot of time in the Agency of Human Services across our department and our central office talking about the challenges that we face. But there's some amazing work that our staff do every single day. And so one of the questions in the budget process that folks asked us to cover this year was, well, what are some of the outcomes? And these are some of the things that our team can be proud of. As Vermont being what we are, we never anticipated that we would get get one of the highest per capita amounts under the Rural Health Transformation Funds, and I really want to celebrate the team that did that. So, Senator Lyons, your point is well made. There's a lot of work to still be done, and we are working on your priorities.
Well, I think you should celebrate the work that you are doing on it because it is significant.
Yeah. Thank you. Appreciate that.
And so the refugees still are not eligible for SNAP, because I thought there was some question about whether that was the Fed rule or not. Some other states have not done it, but Vermont.
That is a deep legal question.
We don't need to go into that.
Yes, and I'm sure DCF would be happy to answer it in some detail, but there are definitely groups that the federal government carved out.
This next slide is just a snippet from the AHS ups and downs, which that is one of the supplemental documents that's uploaded on the website. It's the full packet of all AHS departments, the ups and downs.
How many pages is the whole thing?
What's that?
How many pages? Like 80 pages?
No, I think it's in the 30s.
Okay. This is just the best one?
Yeah, this is just the Secretary's office. And then just to go in a little bit more detail of the budget changes in the central office. There's a $2.8 million reduction for the ADS service level agreement. This is due to ADS shifting their billing model more towards core enterprise services. And so that's a reduction for central office. $158,000 reduction in the operating expense that we mentioned earlier. $500,000 for the refugee transitional housing we mentioned earlier. The next two items we haven't mentioned yet. $17,000 for field service coordination. There were two districts within the field services realm that had extra support for complex cases. And so we're now treating all of the field services equitable. And so they have other resources that they can use for those cases. And then a reduction of $19,000 for the foster grandparent program that ended at United Way. This was used as state match for one of their federal programs, but they ceased the program on their own, and so this match is no longer needed. There are two other areas that the central office provides support for. The Developmental Disabilities Council, which is 100% federally funded, 3 positions, and the Human Services Board, which is split between general fund and federal funds, and that has 5 positions. And so the only changes in those 2 appropriations are salary and fringe. And
so there's 7 members, but only 5 of them are paid? Is that, why is there 7 members of five positions?
So these are the positions that support the board.
Oh.
So they're not actually the board members, but this administrative
The
staff
board
or legal
members
staff.
also get paid through your budget?
The per diems, yes.
Just the per diem?
Yeah, this is not the per diem. The per diems is part of the 940.
So these are like the lawyer, you have lawyers that have served the board, do you know?
Yes.
Right.
Well, like Joe Reiner. Yes.
Yeah.
Mhm.
Okay.
Yes, there's attorneys, yes. Okay, and then also within AHS central office is the global commitment appropriation, which serves as the mixing bowl that combines all the state and federal match for the 1115 global commitment waiver. We talked about the FMAP percentage earlier. And also, there's language in the governor's recommend budget to allow us to seek a renewal for our 1115 waiver. We need to submit our application within the next year, and we will start negotiating with CMS. So the language authorizes us to seek that waiver. And the whole budget for global commitment is $2.2 billion. And on the right side, you'll see the breakdown of the various fund sources.
So one of your ups and downs real quick, you did a good on the ADS SLA, being going down 2.8 million. What we've seen in other agencies' budget that there was an up somewhere else for ADS.
Yes,
Did
yes.
you also experience that? Where, so that up, what I'd have to look at the 30-page sheet to find that,
Yeah, for each
Yeah.
department, correct,
because it would be split between.
correct.
But the savings is here in the central office.
Correct, yeah, so our ADS allocation charge was up for the core enterprise services, all funds, $203,000.
Well, that's a pretty good delta. If you say 2.8 and went up 0.2, that's.
But there's two, caveat, the 2.8 is for all departments, so.
Right, so just review, just
Yeah,
here.
yeah.
Okay, that's what I thought. Okay, go ahead.
Okay, there's a snippet of the global commitment ups and downs. And then, this is everything we've already talked about earlier, all the changes related to FMAP. You know, the ups for the base FMAP change, the decrease for childless to adult 90%, the CCBHC enhanced FMAP rate. And then all of the departmental changes for global commitment, it's actually a $23.3 million increase.
And then in this next year, do you do the new 1115 waiver?
Yes,
Is there a cost to that? Like, is that, or you just, because you don't know what the waiver is going to be, but is there a cost to do the negotiations?
There is a cost to the negotiation.
But it's not a major,
yeah, we have a contract for both technical assistance and actuarial assistance, and we have that within our budget.
and are there other risks to that
For
process?
the waiver process?
Yeah, I mean, like, because they could just come out with a new FMAP
So,
calculation.
yeah, so it's not a new FMAP, because FMAP
Right,
is across
right.
all Medicaid
Right,
states.
right.
There have been very few states that have gone through the 1115 waiver negotiations in the last year and a half. And so there are areas that we can hypothesize, but we don't have enough information to show where there may be risks or not risks at this point in time.
And that's probably the same throughout all parts, all your departments, and how they're affected by the, you don't have any way to prepare for what next
Correct,
break is gonna fall.
yeah, there are definitely some things that they have put out information that we know that they anticipate not funding. For example, they've been really clear that there are certain health-related social needs. And by that, one example of that is the ability to pay for 6 months of someone's rent using Medicaid dollars. They don't consider that a healthcare service unless there's a specific healthcare need. So at this point, we have not implemented that portion of our waiver because we don't anticipate being successful. Other boogeymen, I don't know yet. There's just not enough information to know what the priorities are yet for this administration concretely based on what they've actually negotiated versus what we're hearing.
Okay. Caroline, any question?
No, I'll say one.
Okay.
Thank you.
Here's a snippet of our grants out to, that come out of the secretary's office. And then just a reference for the supplemental documents that are available on your website, our ups and downs, that summary budget sheet, our 25 carry forward and reversion list, a list of single audit findings from the previous year, and the 1% community-based provider cover increase.
So we have 4 documents on our website. So one of these we got here.
I think the last 3 items are all combined into one document.
Oh, right.
So you got the slides plus those.
Mr. Chair?
Yes.
I would be interested in more on the repayment program. In particular, you talked about the rural transformation money allowing tuition payment. I'd be interested to know what you expect that pot to look like compared to what you're eliminating, and who might not be able to take advantage of that.
Absolutely, we can bring that back in. One of the questions I figured somebody would ask and didn't, and Jill, I'm gonna put you on the spot, you may not know, we may have to come back. How much money is in the workforce bucket of the rural health transformation? Oh, I'm gonna phone a friend.
About 8 million.
Okay,
And there are some specific things that we are not allowed to use the funding for, specifically providers. That's one that's called out very explicitly in the
yeah,
Providers meaning physicians.
physicians and APPs.
yeah, okay. Yeah, whatever you can get us on that, that's the only thing that gives me some pause.
Yeah, thank you. We're hearing lots of questions about both workforce, what we're doing in rural health transformation, and about the decision for repayment. So I appreciate everyone's helping us work through that. We'll definitely be back with more information.
So I'm looking at the supplemental data on 1% increases. Can we get, can I get, I guess, I don't know, probably would go to our committee, but it would come here as well. 1% increase on primary care. What would it be for an increase in primary care?
Yeah.
To, right now, I think Blueprint is what, 110% of Medicare?
I'm not following you with it.
I'd like to know how much more we'd have to invest to increase Medicaid reimbursement for primary care by
1%.
1%, 2%, 5%. Is that possible?
Yeah, you're looking for Medicaid reimbursement increases.
Yes.
I'd also like to be able to make sure to bring to you the dollar amounts that are
Yes.
that are coming from rural health transformation, because there are significant dollars that are earmarked for primary care in the rural health transformation fund. Some of those we're just trying to figure out whether we can pay them out in the way we thought. But again, there's significant.
Okay.
Like,
That would be
$40 million for primary care in rural health. Tracy's sick, or was sick. She's getting better, so she's just coughing.
Now we're all sick.
No, she's
No,
not
I know.
contagious anymore, but I saw everyone's alarm as she got up and stepped up.
Okay, good, thank you.
Yeah, so we can provide that 1%, but I'd also like to make sure to provide with that how much funds are in the rural health transformation.
Any other last comments or questions of the Commission Secretary? All right, thanks for your time,
Thank you.
presentation.
Thank you.
A lot for us to look through.